It's not a massive
The
issue.
light should be in front of you, so it's easier.
The professional.
I don't know about professional. I think I've been doing this for too long.
Grace, do let us know before you go live.
That can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our Health Hour sessions. Spread the word in our community. CATHIB is funded by the National Lottery Community Fund.
Well, good morning, good morning, good morning. Thank you so much for joining us once again for another CATHIB Health Hour. My name is Joseph. I'm one of the GPs here that I come in quite regularly around here, so many of us would know me. These health hours are designed for you. They are CATHIB's way of reaching out to the community to make sure that we educate the community, we rub minds together, we look at the problems that we have and look at ways of solving it. CATHIB is in partnership with the Rafa Health International Organization, with Croydon BME Forum, FEF, the Enfield Caribbean Association, the BHI, as well as RCCG Sheffield. All right, many of us know the format already, but just to remind us, we'll have a presenter who will present for about 20 or 30 minutes, and after which we will have some time to have a question and answer session. Please put your question and answers either in the chat, or if you're watching on YouTube, you can put it in the comment section, and our lovely team will pick it up and we will endeavor to answer it. We encourage you not to ask specific questions about specific scenarios, but rather generalized subjects so that we can try and address it and in time. So today we're going to be talking about pain management and overcoming the fear of surgery. Pain management and overcoming the fear of surgery. We have a lovely presenter today. She is a specialty doctor in anesthesia. She works in the Southport area. She's somebody that is quite well known to me. Her full names are Dr. Oluyemisi Amanda Adigwe. I just call her Doc Amanda. Please welcome Dr. Adigwe, everybody.
Thank you very much, Dr. Joe. It's a delight to be here.
Please go for it, Yemisi. The floor is yours.
Okay. All right. So, as Dr. Joe has said, I'm an anesthetist, and pain is one of the things that we have to deal with. I like to tell my patients that we're the ones that make them not know the shenanigans the surgeons are up to. Of course, the good shenanigans, but you get what I mean. So I will be taking a presentation on management of pain and fear of surgery. Just give me a minute to start the slideshow. Yeah. Okay. So, first and foremost, let's just see what we're discussing. So the discussion points, we're going to be talking about what pain is, types of pain, assessing pain, treating pain, preparing for surgery. We'll explore the issues behind why we fear surgery, and we'll talk about how to handle these fears. Before I go ahead, I think it's really important for all of us to realize that we're being human when we feel pain, or even when we are scared of what could happen when we go into surgery. And I'm just hoping that as we discuss this, number one, we're able to pardon ourselves for some of our thoughts, but understand them better, and see how to go around them. But first, let's talk about pain. Now, pain has a very interesting definition from the International Association for the Study of Pain, and it is called an unpleasant sensory and emotional experience. That's, how you feel, from your five senses and also with your mind. And it is associated with or resembling that associated with actual or potential tissue damage. So that you don't have to see somebody with a big gash on his leg to know that he's in pain, And another important thing that we work with, another important definition is pain is what the person says it is. Okay, so people have different perceptions of pain. It is not for you to say, go Joe, as in I had something bigger than that and I bore it. You can't be in pain. Pain is what the person says it is. Why? Because there's so many factors that come to play in how a person perceives pain, and everyone is different. It's a very individualized and personalized experience. So let's, as I was saying, we're talking about pain being, it's a personal experience, and it's influenced to varying degrees by many factors, psychological factors, social factors. People learn the concept of pain through their life experiences, and therefore a person's report of an experience that is painful should be respected. I will give an example. A lot of us come from, we're either African or Caribbean. I'll give an example from, my country, where I come from, Nigeria. You have the country, you can divide the country largely into east, west, north, southeast. The northerners are very good with bearing pain. You can see a northern woman in labor. She'll just give some few hums for the whole labor, and she's delivered her baby. Or if you get someone from my side, from the West, oh goodness, I worked in the West, they will speak their life history. The ones that will speak in their language, I will not do this again. This is my last time. I don't know why they would say all sorts in, labor, and it's the same labor. It's, technically you can say it's the same kind of pain. You get what I mean? But cultural factors, psychological factors, many things influence how people, perceive pain. But the woman who's not screaming and shouting, do not think that she's not in pain. It's just that for different reasons, she has a higher threshold. Even without cultural factors, there are people, everybody knows this, in your own household, there's one person who, if they have a little headache, it's like they're just about to die. Let them just lie down, and just, forget, But then you have other people who would have more debilitating, problems causing pain, and they'll be moving around the house. There are some jokes that have said, well, when mommies are sick, they can still do many things. When daddies are well, that's a joke, sharp, but you get what we mean. So, in essence, people express pain differently. So, although usually pain serves as an adaptive role, and why do we say this? Pain helps you to adapt to your environment. Pain is good, actually, can be good in the sense that it warns you. So, there are some things that you even try and teach a baby. You understand? Don't touch that hot thing, and the baby just decides, no, this is what I want to do. But then, have a little feel of it, feel the pain, and you draw back, and it teaches you not to go back there again. So pain, over time is kind of like a way to protect us, from the dangers of our environment. But it can actually have adverse effects on our physical, social, and psychological well-being, as I'm sure we all know. And we will all have experienced pain in one way or the other at some point or the other. Verbal description is only one of several behaviors to express pain. The fact that someone does not communicate does not mean that a human or even an animal is not experiencing pain. And that's something that's really important to understand. And I know that a lot of people may resonate with this because sometimes you may not have obvious sources of pain. And when you complain, sometimes it just looks like, what's this person talking about? And sometimes you just don't say anything, but the pain is there. Now we're going to talk about types of pain to try and understand it better. I've tried to make this really non-medical, so hopefully these are one of the few medical terms that you will see. But then you have, and I'm only using them because it also relates to another classification of pain that will be easier to relate with. So you have the nociceptive pain, which refers to pain from tissue damage or inflammation. Okay, it's usually acute, a short period of time. So if you are cutting tomatoes in the kitchen and you injure yourself with a kitchen knife, you will feel pain. Tissue damage has occurred. There will be inflammation. It will get red, swell up. Over time, it will heal. Okay, and this nociceptive pain is this, it's been divided into somatic and visceral. So somatic is, let's just say, from the musculoskeletal system, your muscle, your bones, and then you have visceral pain, which is from the organs inside, the ones you can't see. So usually somatic pain will be achy, dull, throbbing, sore, and usually localized. Okay, so if someone has had a fracture, someone has had an operation, the operation site, or an infection, someone has a boil, oh my God, they can be painful, and then you have visceral pain. So the organs inside, it's usually gnawing, squeezing, cramping. Sometimes, remember, if you have a tummy ache, you can't describe it. In Nigeria, we will say things like, does it squeeze you and release you, squeeze you and release you? That's like a colicky pain, or those kind of pains that you can't really put a finger to where it's coming from. It can be diffused and polylocalized. It can be referred. And that's another weird thing. You might feel pain in one place and you can have the pain go to another place because the nerves, supplying these adjoining areas kind of like travel through, the path that joins both of them, so, that's a way to explain it. And then neuropathic is usually chronic, usually greater than 3 months, so long-standing. It's usually caused by chronic progressive nerve disease and can also occur as a result of injury or infection when the recovery period is now protracted, and extended. Okay, so can I just say, Dr. Joe, did you say that questions will be at the end, or am I supposed to be watching out for questions?
No, we'll take questions at the end.
Okay, all right. So now let's go to acute pain. We talked about the fact that acute pain is usually nociceptive pain where you have, tissue damage, inflammation, and related to injury, illness, recent surgery. Usually lasts less than a week or two. Management is usually straightforward with painkillers, medications, and some other treatments if required. And the pain usually ends after the underlying cause has been treated or resolved. Someone has a fracture, even if he has to be in bed for 6 weeks with, pins sticking out of his leg, because he had a fixation or whatever it is, you find out that the pain wears off after a while. Okay. But then you have chronic pain, which I will talk a little bit about more because it is less understood. And people who have chronic pain many times feel misunderstood, misrepresented, people tend to feel maybe they're exaggerating things sometimes because you've given them all sorts of treatment and you're still coming back, But I think it's important for everybody, both medical personnel and the people suffering and the people taking care of them, their friends and loved ones, to understand that there are many things that come to play when somebody is suffering from chronic pain. But what exactly is chronic pain? It's long-standing pain that persists beyond the usual recovery period of maybe an acute pain, or even just a condition that in itself would cause protracted pain. And usually you'd say above 3 months. It can be on and off, it can be continuous. Many times it affects work, physical activity, and living in general. and it causes what they call the terrible triad of suffering, sleeplessness, and sadness. It's a major medical condition that can and should be treated, okay? If we look at this little diagram here, it talks about, gives different examples of, chronic pain. So nerve pain, that's very difficult to treat. So you have people who just, you've given them everything and they're still having pain. So you can have sciatica, those who have complications of diabetes, who now have, nerves affected, could have, that kind of chronic pain as well. People with muscle pain, so hips, legs, neck, shoulders, like someone has arthritis, even though it might cause an acute pain at the beginning, but, all that wear and tear generally may not reverse itself. So you might have that tendency to have a chronic pain from that. Mechanical compressive pain. So some people have maybe a disc bulge or a nerve entrapment. They can cause very, very painful conditions. And then we talked about arthritis, infection, tissue injury. Sometimes it's acute injury that doesn't recover in time, and you have people who now have to be on protracted treatment for pain. So this is the chronic pain cycle. You can start from anywhere, but let's start from pain. So you have pain, and then anxiety that pain is signaling tissue damage and harm. Because it's true. I mean, you have pain, the doctors have given you everything, you go there and they say, oh, there's nothing else we can, are you sure you're still feeling this pain? And then they begin to have anxiety, the brain becomes more focused on the problem. Then you have changes actually taking place in the nervous system, more pain, more anxiety and less movement, more changes to the nervous system, and it's a vicious cycle. So eventually, like we said, you have people who are sad, depressed, unhappy, and they're suffering, so chronic pain can be terrible. We'll go back to how to treat and handle this, but let's now go to assessing pain. We've talked a lot about pain, but how do we even assess how much pain somebody's having? And why do we need to assess it? Why don't we just believe what you say? I mean, and just, oh, it's pain, so we'll treat it. It's because there's no one size fits all treatment. You need to assess pain to determine severity. You need to assess pain to determine the effectiveness of therapy. So if I've started treating, or you're on treatment, you want to be able to say, oh, before it was a 9/10, now it's a 4/10. Then we know that treatment is working. Maybe we'll give you something more, or just give the treatment more time, It also helps to compare drug potencies. So you're like, I use this and I feel better. I use this, I don't feel so good. So we'll decide on the treatment plan for you. Determine the most appropriate drug and route of administration. If somebody comes with, for instance, has been involved in a road traffic accident, okay, and has, like a terrible fracture and a limb hanging, and somebody comes with a headache, you will give one paracetamol tablets. The other one, you will definitely give something, much, much, much more potent. So obviously, and you won't give him by mouth, at that point in time, very likely. So these are just reasons why we assess. So now we're going to go to how we assess this. And we might be familiar with many of these things, going to hospitals sometimes, and, they ask you, how's the pain on a scale of 1 to 10? That's a very popular thing that is asked, okay? So we have different scales, and we'll talk about them. But I just want to add that, as I'm sure we would realize, that it's very difficult to objectively measure pain. Okay, we have talked about the fact that there are many factors that come into play, and everybody is different. And sometimes even the extent of tissue damage from one type might be different from in another person from the same type. Okay, a lot of us experience everyday pain, headaches, minor injuries, and these many times don't need treatment. Okay, but pain perception, especially when it's more severe, depends on how we're feeling, our past experience of pain, worries we have about the cause of pain. Like, let's make this really simple. Go down to brass tacks. When you have children at home, for instance, okay, and they stumble on the rug and fall, you may have them cry in anguish as if the world has just fallen down around them. They just want a cuddle. You know that. They just want your attention. There's absolutely no pain. If you are, you can, what's wrong with this person? But they just, so sometimes, even as adults, our emotional needs, our problems, our state of mind, our emotions can affect how we express pain. The truth of the matter is, even something as it may sound silly, but someone even in a bad marriage may exaggerate pain more because he or she feels the other person won't give me attention either way. So there are so many factors, and it's really important for us to be sensitive when anybody's feeling pain, and because there are many factors involved. Anxiety, depression, post-traumatic stress disorder, emotional or mental health challenges may worsen our experience of pain and make it more difficult to treat. I've had patients where you want to do a very simple thing. If you're not careful, you're just like, what is this? A very simple procedure. Maybe just take, I know it's not that easy. Don't worry. I've had bloods taken even recently. Yeah, it wasn't easy at all. But, something that a lot of people just grit their teeth and bear. You'll have somebody, we've had to do general anesthesia to take bloods from someone. And why? Because she had a very traumatic experience as a child. And she just could not bear the thought of having that pain. Now, that's her experience. Do you get what I mean? And it is a valid experience. So just to buttress again and again that pain and the perception of it depends on things that we have experienced. People also constitutionally have different responses to similar level of pain. Some people are just stoic. You understand, whether they are going through anything or not, they can handle, any level of pain. Going back to my example of even some people from certain parts of the world, I gave examples from Nigeria, but obviously everybody will have an example about some people who just can manage, maybe tribes or, whatever it is, areas. So it can be a difficult task assessing pain. But remember what we said at the beginning. It's what the patient says it is. So if they say it's 10 over 10, you're not supposed to say, how can it be 10? It cannot be 10. You're supposed to believe what they have said. But also as a clinician, you still wisely treat, because a lot of people mask dependence on drugs, and come and exaggerate their pain. I know Dr. Joe will be familiar with that. People come and say, I need some morphine, I need some this, I need some that, but it's just dependence. It's not so much pain, but it's always that, trying to juggle that, so the onus is on us to be as truthful as we can to express, what we feel. All right, so we were talking about how to assess, and there are different skills. So nothing highfalutin. These are things that, you can encounter anywhere, and they ask you, what do you feel on a scale of 0 to 3? Can you tell me how much pain? Where 0 is no pain, 1 is mild pain, 2 is moderate pain, 3 is severe pain, So it guides us on what to give you. If you say, oh, no pain or discomfort, then you don't have anything. Mild pain may give you some, you may not even need some oral medication. Moderate pain, you might need severe pain, you might need some more, so it depends. So, but these are things they can ask you, and you can respond to it. You also have a numerical rating scale. This is really popular on a scale of 1 to 10. Oh, it's 4, it's 7. We ask that a lot. For instance, when we do, as an anesthetist, I do labor epidurals. I'm sure a lot of you will be familiar with that. And, the woman is shouting at the beginning of the procedure. She's in the throes of labor. You can hardly get her to sit still. And then you do it. And then the lady says, she just starts to sleep or snore. And then it's working. Or you ask on a scale. So the epidural doesn't start to work immediately. It takes a little time. So what you tell them is it takes some time to work. So I'm going to ask you how you feel now. So they'll tell you a scale of 10 or 11 or whatever it is when you start. And then when you put it in, you might get, oh, it's now down to 4 or 5. Then it's working, and you eventually get to a place where it's down to 0. Okay. I'll give a little funny example here. I had a young lady who came in. She was I'd say a teen mom. So she wasn't the best behaved, she was really, upsetting everybody, let's put it that way. And she had the epidural, and when she had the epidural, she stopped screaming. So I asked her, I said, how do you feel now? She said, well, I'm just bearing it now. I'm just enduring it now. I was like, you're not enduring it. The pain has stopped. but she didn't want to, so you can see behavioral, and there's a behavioral aspect to how people perceive or react to pain. But yeah, the numerical rating skill. And then the visual analog skill. You have where they'll just give you a picture and tell you to point out what you feel. There are quite a few explanations here on whatever it is, but then if you feel really bad, really, really bad, worst pain possible, usually they tie it to a numerical scale as well. But these are things they can ask you. In hospital, many times as an inpatient, what we want to know, what the doctors and nurses want to know is usually, do you feel any pain? Do you feel pain when you move? Slight pain, moderate pain on movement, continuous pain at rest? Because, you have to turn the patient sometimes or take them up for physio. And we use that. And at that time, they're ill, you can't be asking them too many questions or pointing out charts or stuff like that. So this generally helps to give, a good picture. So how do we treat pain? We have to treat it, don't we? And the gold standard is to do multimodal treatment, which is when you give different classes of drugs. And that just simply means, of course, you start from somewhere, but if the person needs more, then you want to give different classes, not that you're going to give like a maximum dose of one before you move to another, because it just helps to, many of the drugs attack pain from different angles of the nervous system. So there's a pain pathway, which we won't go into, but the drugs attack different areas of that pathway. So when you use different drugs, you're kind of like, having them work at different areas, so the efficacy is higher, and then because many drugs have side effects as well, if you're able to use a little of this, a little of that, a little of that, you're able to reduce the side effects profile of each one. Usually, what we do with mild pain, we start with paracetamol and what we call a non-steroidal anti-inflammatory drug, which to you would be drugs like ibuprofen, diclofenac, ketorolac. Don't know if you used ketorolac in the community, but you get what I mean, ibuprofen and stuff. Then, if the pain is a bit more than that, they might go to paracetamol, ibuprofen, maybe add some codeine to it, like a weak opioid. And then for something stronger, many times surgical pain or really painful, like, an accident or a heart attack, where there's, severe chest pain, crushing chest pain, they might now go to really strong opioids like morphine, oxycodone, and, stuff like that. So generally, that's the general idea about how treatment is done. So if you go with pain and it does look mild or moderate, they won't slap you with the highest level of medication. Because why? It's better not to take any meds if you can help it. So we'll start from, and it's a stepwise progression. So these are just examples which you might have encountered. Some of them are off the counter, some are not. But there are many routes of administration that we can give them through. So they can go through the mouth, they can go under the tongue, they can go in the muscle, which is probably one of the most hateful ones. And they can go under the skin, into the vein, and then we have the beautiful epidurals. Epidurals are not only for labor, you also can use them for, operations where, you want to treat pain for several days, and you can keep putting in very strong painkillers called local anesthetics into the lower part of the back. I don't like saying spine because I think that really scares people, but you put that in and then it just helps to numb the nerves and give good pain relief. So epidurals are also things that might be offered to you for people who have chronic back pain, who have things going on back there in their spine, or people who have some really extensive surgeries, where the epidural would be useful. Okay. In terms for chronic pain, remember we talked about chronic pain takes a long time. Many of these drugs that we talked about wouldn't do anything. Most likely they will start from there to treat, but what they will need strong, more things to help with the nerve aspect of it. Remember we talked about it was not just, it weren't only talking about tissue damage and inflammation. Now we're talking about neuropathic pain, which was pain to do with the nerves, okay? So prescription antidepressants. So when you hear people on set, if you're familiar with antidepressants and you hear someone saying, oh, I'm amitriptyline, it's not all the time, it's for actual depression. Sometimes it's for pain. There are other things, heat and cold treatments, for people with, stiffness and pain, who have joint problems, physical and occupational therapy. I'm sure a few people might have had to do physiotherapy, for one thing or the other. Exercise, that helps, always. Things like local electrical stimulation, injection therapies, like I said, epidural steroid injection. So we can inject steroids into the epidural space to help with, lumbar, back pain, lumbar pain, and things like that. So there are quite a few things that can be done, for those with chronic pain, because they need more than just the usual medications. Okay. There are also other things that need to be factored: emotional and psychological support for someone who's having protracted pain. So psychotherapy, group therapy, stress management, relaxation training, meditation, hypnosis, biofeedback, behavioral changes, whatever works for whoever. This picture just kind of like shows, different ways, so you want to work on the mind, you want to work on the heart, you want to work on the body, the muscles, you want to work generally. It's kind of like trying to ensure emotional and psychological well-being to promote physical well-being. An important part of treating chronic pain is kind of putting the person in charge of controlling their pain, because there's a very strong temptation to feel like a victim. Not that that's bad, but if you wallow in that, it becomes a cycle. You don't get out of that pain. But then kind of like thinking outside, how can I manage my life? How can I still live my life? And how can I even improve my chances of getting out of this pain? So changing one's attitudes, understanding that unconscious influences, feelings, and behavior can actually contribute to pain. You understand? Sometimes even just the fact that if someone has PTSD, and PTSD is what is contributing to their pain, for instance, if the person is able to recognize that and maybe treat that PTSD with psychotherapy, or the person is a person of faith, work on that, in that regard, you might find that you might be able to help with the pain. So that's what all of these things is talking about. So anyone who's going to treat chronic pain has to factor, it's multifactorial, and has to factor all of these things, not just slap them with drugs and say, take this and go. Okay. Patient and family education and counseling. The family needs to understand, okay, some people just cannot get why you haven't gotten out of this pain. Okay. There's something called fibromyalgia, which is a bit, sometimes difficult to understand. A lot of people, I think, hide under that just not to do anything, but it is a genuine entity, and there are people who actually experience it. They just have generalized pain. They can't do many things, and it has even other symptoms to it. And it's the kind of thing a lot of people say, I don't know what that is. There's nothing wrong with you. Your legs are fine. Your hands are fine. Why are you like this? So patients and family need to be educated and counseled on how to be there for people who are genuinely suffering from chronic pain. And then there are other, could use alternative medicine and therapy treatments like we talked about in the previous slide. And sometimes surgery may be considered for chronic pain. Usually it may not be a permanent relief, but it could bring some level of temporary regression of the pain. So now we're going to talk about, we've talked about pain, we've talked about how types of pain, how to assess, and how to treat. And now we're going to talk about preparing for surgery, because surgery is also a potentially painful experience. Potentially, I say, but it's not usually that way. But beyond that, there are many reasons why people would be anxious about it. But first, let's just talk about, how we even get to the decision of surgery. I'm sure quite a few people would have had surgeries, even if it was not for an illness and it was for cesarean section, you've had a surgery. So why do we decide? There's usually a reason or an indication for it. And surgery could either be an elective procedure, something that can be planned for a good time, and say, oh, we're going to have it here, we'll optimize you, do your bloods, make sure you're fitting well, you sorted things out with your work, your kids, and we're going to have it then. Not necessarily because it's not important, but because in terms of timing, it can wait till that time. Expedited, meaning that maybe it was elective, but it needs to be facilitated a bit quicker. And then emergency, there's no time for anything. Some people come straight from the accident and emergency straight to theater. There's no time to do no niceties, not some level of optimization, but very emergent care because you know that that person's life is threatened. Surgery could be major or minor. Some people could just have maybe a breast lump needing removal. Sometimes can be done under local anesthetic, really minor, but they've gone under the knife anyways. And then surgery can be done under local anesthesia or general anesthesia. Now, what we're going to kind of talk about to help us through the period, and this is for, hopefully we don't have to, but if you have to, just to demystify the period of surgery. If you have any family who's going through it, for you to know how to support them, and just to give you an idea of what to expect. So when surgery has been decided, you have the perioperative period, you have the preoperative period, the intraoperative, and the postoperative, and we'll talk about them. So the preoperative period is where the decision has been made, and you have kind of agreed. You can still back out, but you have kind of agreed that, yes, I think I do need this procedure. Then they do an assessment, and this assessment includes a lot of things. They sit you down and ask you, because one needs to know your medical profile. What other medical issues do you have? So this is a very interesting thing, because this is very key to my job. So you ask a patient and you say, okay, I know what's brought you here. You've come to have a surgery on your hip. Do you have any medical problems? Oh, no, not at all. Fit well. I'm absolutely fine. Okay, that's fine. Are you on any medications? Oh, yes, I'm on ramipril, atorvastatin, citalopram. It's like 3 different diseases treating that. You're like, okay, you do have some medical issues. So I think it's really important for everybody to understand what is going on with you. You cannot outsource your health to a doctor or another person. You need to know. So if you go somewhere and they're treating you for something, or you're on any medications, please know, because those medications I've told you about, one is for hypertension, one is for high cholesterol. You understand? So it's really important to know. But yes, they will ask you about your medical history, because it has an impact. It has an impact of what anesthesia will be done, when the surgery can be done, whether you need to be optimized, and things like that, whether we need to check some other things. So it's good to know. They'll find out about if you had a surgical history. We are very interested in that, as well as the surgeons, the anesthetists and the surgeons, to know if you've had any reactions to anesthesia, if you've had, any problems with previous surgery, or maybe like you say, oh, you're coming for a C-section, the last time you bled and lost 2.5 liters. We will be extra careful, because we know that there's, from experience and knowledge, that there's a higher risk. So it's really important to give as much information as you can. Then they do some blood work. And this many times depends on your age. It depends on your comorbidities. That's other health issues that you have. And it depends on, age, comorbidities. And it depends on what kind of surgery it is. So if it's a minor one and you're a young, fit and well person, they may not do much blood work at all. But if you're older, you have a few things going on, or it's a major surgery, then you'll have some blood work. Dr. Joe, sorry, how many minutes do I have left? Just to be sure I'm not overshooting.
I sent you a message a few minutes ago. I think you have a couple more minutes.
Okay, couple. Okay. So,
but please, by all means, finish your presentation. We've got a few questions, but we do like to take questions.
Okay. All right. So, sorting out. So, yeah. So you do all of that, and then an anesthetist comes to review you. You have the time to begin to sort out a responsible adult to take care of you after the surgery if required, your child care, give you a notice to friends, family, work. Do an informed consent. The surgeons will speak to you about the possible risks, and complications. Then you'll sign, but you'll still do another one just before the surgery. And then they give you instructions, information leaflets on, fasting procedures, so you don't eat just before the surgery, what medications to take or to stop. Okay. And then intraoperatively, that's when you come in, you have the anesthesia, you go in for the procedure. And then postoperative, this is really important. you spend some time after most procedures, you spend some time in recovery, which is an area where you are monitored closely. If for any reason you feel pain or you feel nauseous, usually that doesn't usually happen, but if it does, you'll have some treatment. Or if you're not doing so well after the operation, you will have doctors around who will come and take care. Pain relief, multimodal analgesia, like I talked about, wound care, physiotherapy, mobilization and stuff to help you recover quickly from the operation. Okay, I will just go through this I was told I had a couple of minutes, that's probably gone, but I'll just go through this as quickly as possible. So we talked about the fear of surgery. This is absolutely normal. When people come and tell me they are jittery, I tell them, well, you're just being a human being. If you put many of us in these circumstances, we will have some level of nervousness as well. So it is, why do people fear surgery? I found out, I didn't know this, but there's a definition for it, there's a word for it. It's called tomophobia, and it refers to fear or anxiety caused by forthcoming surgical procedures and or medical interventions. You can describe it as having an intensely irrational fear of putting oneself in the hands of others, surgeons, anesthetists, all the other healthcare workers, losing control of one's body through loss of consciousness or body changes during the surgery, and that's perfectly understandable. So why do people fear surgery? It's fear of the unknown. That's number one, and it's understandable as well. Even sometimes, even the healthcare workers that know, they still get a bit scared, not to talk of if you don't know. Fear of the disease and uncertainty about the future. And yes, some people who have, like, they're being investigated cancer and they need to have an operation, say they're going to check and take some biopsy, it's enough to be scared. Sometimes you're like, I don't even want to know, so these are the things that cause people being scared. Fear of not waking up from anesthesia. I always joke that you shouldn't be scared of us. We're the ones that make you not feel pain, but people are very scared of anesthesia. You're just going to sleep. Where am I going to be? Where, how am I going to wake up? Yeah. So these are valid fears. Lifestyle changes, after a surgery. Some people may come for a bowel surgery. Maybe they have a bowel cancer or they have obstruction and they have to cut off some of their bowel and they have to have like a colostomy bag. That's a big, huge change in lifestyle. You might, some people might be like, I don't want to do that. Deterioration in body image or disability, post-op pain, nausea, vomiting. That's another important thing. People just, the thought of all of that can, make them fear. And fear of death. What if one doesn't come back from theater, and stuff like that. That very rarely happens unless, if it's a dire situation that's 50-50, many times that is communicated to the family. Things that can facilitate this fear: previous bad personal experience, previous bad outcome with a loved one, anxiety disorders. This is very important. Lack of understanding of the severity of the condition requiring surgery. If we take away all the other factors, which sometimes you can't control or is difficult to control, it's really important for you to understand it. Sometimes you're trying to explain to someone and you think it's because they don't really grasp the severity of what's happening. Otherwise, some people would agree. So it's important to know. Poor emotional, psychological well-being prior to that. I think this is my last slide. Handling your fears. And just a few points here. Prioritize your health. Be involved in the journey from preventive to curative. And that means the truth is there are many issues that require surgery, or there are some that maybe could be prevented. Do you get what I mean? Like if it's related to lifestyle, for instance, if someone has a heart attack and has to have a surgery, like a coronary bypass graft, there was a story I read of someone who absolutely refused it because he was totally scared, but he had a bad heart attack and he should have had it. So what can you do? Just try and, be as healthy as you can. And that is not saying that if you're as healthy as you can, you won't need surgery, but you get my point. Request information, research about your condition, understand the process, okay? Never be vague about what's happening with you. Ask your doctors. If no doctor here in the UK is going to, flagellate you for wanting to know more. So ask details. If you don't understand it, ask again. Ask for information leaflets. Go to the internet, read. Don't read rubbish though. But, try and understand the process. What's happening? After this meeting, what's going to happen next? I have to say that coming from maybe the typical African setting, maybe healthcare is so much better in terms of educating and telling and carrying the patient along, but there are still lapses. I can tell you that, where sometimes patients are still confused about what's happening with them. So, take control of your knowledge about what's happening. You may explore second opinions, alternative options where applicable. And when you do that, you might find that, this is really the best thing. I've read all around it. I've asked people, I've asked other specialists, think I really need to go for the surgery. have a support system, family, friends, religious affiliations. Don't be alone, and take care of yourself as best as you can. Understand how you heal and be easy on yourself. That's it. Thank you very much.
Wow. Okay. Thank you, Dr. Amanda Adigwe. That is a very, very extensive presentation. If we could just get you, if you could stop sharing so that we can get you and I back on the main screens.
Okay.
So there's quite a few. Brilliant. So Amanda, I know this is your first time on the Catholic Health Hour, and you've done an amazing job of taking us through, a very, very complex subject, I must say, because pain management is a rather complex subject, even for us doctors. It's very, very, very brilliant and exhaustive. And I think we may have to find time to bring you back to look into this again. But there are some interesting questions here. Someone has said, and there's a lot of things that you said that I really like. Pain is personal. That's really important, because sometimes we have a culture of castigating or stigmatizing people. Why are you feeling pain? I broke my ankle too. How come I'm not, how come, pain is personal. There's a lovely question here from the social media that says, how do I know when my child is in pain, especially when they're not very verbal? What are the telltale signs that I can use to understand if my child is in pain or not? Do you want to shed more light on that?
Okay, thank you very much for that question. My first thing I'll say is, like we have said, pain is personal. For a child, you kind of, in a way, are their eyes and ears. So to some extent, you would be familiar with their nonverbal language. But definitely when a child is in pain, they're very likely to be irritable and cry, be inconsolable. Even when you give them what normally is a sure banker to have them, quiet or happy, that they're not. And then you would need to observe. There's no easy answer to this, because number one, it would depend on your child. It would depend on understanding how children do things. But then you also need to be observant. It might just be, for instance, like I think we had a child coming for surgery at some point who had, she had something stuck in her knee, so it wasn't all the time, but if she ever got on all fours, she would wince and cry, and then it wasn't clear. They couldn't see it. So they now needed to examine and finally find that there was kind of like a little knob on the knee. And then we had to take her into surgery and take it out. So it's understanding your child and just being extra sensitive to when they're irritable and inconsolable. And you've given them their favorite food, their favorite toy, their favorite cartoon, then there's something wrong. Yeah.
Thank you. I think you did touch on this, during your presentation, that, different people would present with pain in different ways. I remember being a junior doctor in A&E, and a girl walked in with a dad. She must have been about 11 years old. And she would only get pain in certain positions. Okay. It's funny because the dad was understanding, but the mom was like, she's always a drama queen.
Yes, and, exactly.
Eventually, she had a green stick fracture. She had a a green stick fracture is a fracture that doesn't dislodge the entire bone, but it's cracked. That happens a lot in young children. And so it was just the fact that the child wasn't quite herself. And dad, being maybe somewhat closer to the girl, understood that she wasn't making it up, that there was actually something going on there. And so just to buttress your point on knowing your child, and looking out for subtle signs and things that could be, we also talk about this when we look into safeguarding and things like that. There's a lovely question here that touched on a few of the last points that you made. So I'm due to go for knee surgery, and I've been putting it off because I'm concerned. What should I do? I'm worried about the surgery. What should I do? That's somebody from social media.
Okay.
What would you advise this person in 60 seconds?
Okay, first and foremost, you internalize within yourself if you think you really need that surgery. Are you incapacitated because of that knee? what have the doctors talked to you about? Have they shown you imaging to let you know that, yes, there's really something wrong? Look at the statistics. I can tell you that knee surgeries are a dime a dozen in the NHS, and they're just generally straightforward. I can tell you that. Look at the anesthetic options. There's the option to be totally knocked out and asleep. There's the option to just have a spinal anesthetic and you'll be awake and you can chat with the anesthetist. You can look not necessarily, but you get what I mean. You can see what's happening because some people just want to be more in control. Some people don't want to be. So you can actually, how do I put it, fashion your environment, in a restricted way to maybe get a better experience, but if you need it, go for it, I'd say. So just research and speak to your doctors, talk to them about your anxieties and let them go through the procedure again with you, and then you might be able to talk to other people who've had knee surgeries and they'll tell you, yeah, it wasn't a big deal. That being said, there's no medical procedure that's 100% guaranteed. But if it's a straightforward knee surgery, usually it's fine.
Thank you, Dr. Amanda. That is true. I mean, generally operations are getting more and more, getting safer and safer and safer. That is not to say that there won't be complications sometimes, but operations are generally, and with most things, probably the earlier you get it, the better for you before the knee gets so bad that it gets so bad, because I worked with a knee surgeon years back. It gets so bad that even when they operate on it, you don't get the right kind of results that you want. So it's probably best, like Dr. Amanda said, speak to your doctors, have a chat, look at the pros and cons and see how you go with that. Another interesting question: I suffer with chronic pain, and the connotation is that my boss is not very understanding. How do I explain to them my chronic pain, and where do I go from here in terms of making them understand my chronic pain?
Okay, so I think it's understanding things from both sides, right? If you have chronic pain and you're not able to do your best at work, that will be a problem for your work. And it may be understandable that they may have issues with it. But first and foremost, you need to be able to prove that you have valid reasons to be off. So don't be responsible about getting your sick offs or whatever it is, so that it doesn't look like, oh, I just didn't go to work today, I didn't go to work tomorrow. You might get like a comprehensive medical, note or whatever to explain. And then what I would say is that explore all the different options. I can't, we don't have much time. I don't know how much treatment you've been able to have, but we did say that there are actually, there's a wider range of, both medications and other things that you can do to actually help you. Because beyond your job, for yourself, you need to be able to be functional and at least enjoy life and live life. So if you can try and explore these things, you can go to your, GP, ask that, can I speak to a pain service? Can I be, referred to a pain service if you're not already with them, so you can get appropriate treatment. And then try and, how do I put it? Suggest ways you can still have good output at work despite your, issues. For instance, if you can't, I don't know the scenario and there's not much time like we talked about, but assuming you had to go into work, would you talk about working from home? Assuming you already work from home, but sometimes you're having issues, can you talk about working out of hours? Can I, as long as, if you don't restrict me to 8 to 5, can I do, can I just try and sort it out by the end of the day? Can you give me like a different deadline? That kind of thing, but they see you're making effort. So kind of like meet halfway is what I'd say.
I think this is a GP question, to be fair, because this is something that we deal with on a regular basis. So if you're undergoing a procedure, pain, and you're being managed for chronic pain, and there's a definitive diagnosis, one of the things we can do is to write you a supporting letter, and you can approach your GP to do that, to say XYZ is actually undergoing treatment, and we can write you a letter of support. Usually many GPs will charge. It's not much. I think it's 30 or 40 pounds, depending on where you live. If you live in Winslow and all that, it may be a little bit more. And if you live in Hillbands, it may be even more. But by and large, you'll get a letter from the GP. The other thing is, if you're facing issues at work, there are support systems. You can go to the Citizens Advice Bureau, get some help. There are different unions that support that. So please don't suffer in silence, because one of the things that happens with a lot of Caribbean and African people is that we melt into the shadow, we suffer in silence. And part of what we do here is we encourage people. There's an advocacy team, for example, that helps you to advocate for your rights here in Cannes. So please, in the chat group, let's put the details on there. We also have a counseling group here in Cannes that helps you with that. All these services are free of charge. They're being sponsored by donations and things from the Latino Lottery and also from other individuals. Right. I have, on a lighter note, you mentioned about different parts for people in different countries, different people from different parts of the world or different parts of certain. I won't talk about Nigeria because there are a lot of drama people in Nigeria, almost as bad as Ghana, but yeah, and there's an ongoing debate here about Ghana jollof rice and Nigerian jollof rice, and I'm leaning nowadays more towards Ghanaian jollof rice, but I can't say that in public. I can't say it in public, but I'm seriously leaning towards Ghana jollof rice. Is there any evidence to show that there is a diversity of how we react to pain from an ethnic perspective? Is there any scientific proof? Because I have been in a situation, because my wife was in labor and I worked in a maternity unit, and there's this stigma, for example, for Asian women and some Caribbean women, where they think that we're drama queens and we is there any specific scientific evidence to show that there is some sort of dichotomy or difference?
Well, that's an interesting question. To be honest, I haven't explored any research that has said that, or rather, I don't have any other tips on my fingers, but anecdotally, yes, that is one thing everybody will tell you. From just being in a healthcare setting, you will see that. But yeah, I don't have any research. I could actually look it up and send it on the group, but I don't have any.
That would be helpful. That would really be helpful, because I know you talked about pain threshold being individualized, and that's true, and pain being protective. I would just want to encourage you, because some of us joined late. Dr. Amanda gave a very extensive presentation on pain and the origin of pain. I would really encourage you to go back and look into it, because it's really very informative. There's a few things that I wasn't aware of, and she brought them to light. Fibromyalgia, can you talk a little bit more about that? There are some colleagues, there are some doctors even, and some individuals who still believe that it's a myth and it's not an actual illness. This is something that I know that we have referred people to your department for. Can you shed a little bit more light about that?
Well, so yes, it's one of those things that sound a bit nebulous, but it is actually it's actually a thing, and I would explain what even convinced me about it. But it's characterized by widespread pain, increased sensitivity to pain. I think that's where the issue might be. So more like what may not cause pain to you would cause pain to them, to someone with fibromyalgia. But then they also have symptoms like muscle stiffness, difficulty sleeping. There's also the thinking that there's also this like a mental fog, or kind of like they have difficulty remembering things, concentrating on things. Funny enough, apart from just physical symptoms, headaches, irritable bowel syndromes, a feeling of frustration and worry. It's like a potpourri of non-specific things, but generally manifests as just being in constant pain and not being able to even endure what just normal triggers or stimuli that other people would have. I spoke with somebody who told me these were his words. Was he a patient or a staff? And he was saying that his father was one of the first to be diagnosed with it in the with fibromyalgia in a certain area. And he said that it was so debilitating that he couldn't do anything, that he stopped work. And it was clear that it wasn't, he wasn't malingering, to use the word, like just pretending, and all of that. And the person was telling me that, but now a lot of people just say they have fibromyalgia. But he could remember how debilitating it was to his dad and can compare with what many people say they have. And it didn't look, he felt that they weren't the same thing. You know, his father couldn't walk at some point, couldn't move, and he had non-specific pain in so many areas of the body. He was diagnosed with it. That's just what it is. It's chronic pain from different areas. And I think for me, one of the hallmarks would be an increased sensitivity to pain. Obviously there's some psychological thing to it as well, you know.
But are the treatments effective? Are there effective treatments for that? Or is it just something that...
In the end, the treatment is still all that we have discussed. It's just trying to find what works in terms of pharmacological drugs, lifestyle changes, and, you know, many other things that help the mental processes, psychotherapy, physiotherapy, pharmacotherapy. It's not more than that.
Okay, we'll come to psychotherapy in a minute, because there's a lot of my patients who get upset when we refer them to the pain clinic, and then they come back and tell me that, oh, they've referred me to psychological therapy. So I wanted to ask you what role that plays in. But there's a question here, a very specific question that says, my recent MRI results show several bulging discs in my lower back. They also found a bulky uterus. The pain is excruciating. I have numbness in my right leg and severe pain in my lower back on the right. It makes walking and climbing stairs difficult. My GP has referred me to the pain clinic. What can I do in the time being?
Thank you for that question. I think that first and foremost, so the GP has referred, but there seems to be many things going on beyond just that need to be sorted out. So I don't know if there are bulging discs, might need to see a neurosurgeon. The bulky uterus might need to see an ONG doctor to even know what's happening. For them to have sent to a pain clinic, I don't know, maybe they've ruled out things.
So generally, if you have bulging discs, if they're not compressing on the spinal cord, then the neurosurgeon is not interested. Your bulky uterus will depend on your age, whether you're premenopausal, whether you're postmenopausal, or, you know, so that the bulky uterus is a red herring. It depends. The person who asked the question hasn't told us her age, hasn't told us how long she's had the pain for, and things. So this is why we sometimes say specific scenarios may be difficult to address, because there's a lot more information that is required. I think on the surface of things, to be fair, this is more like a GP question.
Yes, absolutely.
Because we're like jack of all trades. I see bulky uteruses all the time. I see bulging discs all the time.
By the time I see them, they're on the theater table, so I see the extreme end of it.
I have a friend in your profession who goes, Joe, don't ask me any questions. I just put them to sleep and I wake them up. You know, so with regards to this specific question, I think obviously if you're in a lot of pain, I would encourage you to go back to your GP and seek some of the painkillers that Dr. Yemisi or Dr. Amanda has mentioned in terms of neuropathic painkillers. So gabapentin, duloxetine, pregabalin, those neuropathic painkillers are usually good for disc problems. But this is something that you're probably best discussing with your GP. In combination, you can also add things like anti-inflammatories or even tramadol. Speaking of tramadol, there's always a danger of addiction with opioids and strong painkillers. Very famously in 2014, the TV personality of Ant and Dec, it was actually Ant McPartlin, who I think he had an injury to his knee and he was prescribed tramadol and he eventually became hooked on tramadol, needed to go into therapy. Can you talk a little bit more about, you know, opioid addiction and being careful with regards to pain relief? Because sometimes people think, oh, they don't want to give me painkiller. They don't want to give me painkiller. Yeah. Is there a reason why we're careful with regards to painkillers?
Yeah, because as you've said, they are drugs of addiction. You would also be more familiar with that because they tend to come to the GPs to ask for prescriptions. From our side of things, we tend to give really heavy opioids, but acutely. And then by the time they're leaving, you know, and recovering post-op and all of that, one starts to taper off the opioids. I think it's a policy in my trust that we don't even send them home with opioids. So you want to control the pain as much as you can before they go home, so they don't have to take but the kind of opioids we'll give will be morphine, oxycodone, things like that. But yes, the truth of the matter is that if you take it so much, the opioids not only cause pain relief, but they give a certain kind of euphoria, which is very helpful on its own. Who doesn't like euphoria? But then somebody who's going through a debilitating or, unhappy period or anxiety, or is anxious would particularly appreciate that kind of lift to his mood. So yes, there is that tendency to take these drugs, and we tend to handle really, really strong drugs. But even when we do in theaters, we have to, if you give a patient from a vial, you have to sign it out, and then when you finish, you have to account for how much you gave and push it out, because even medical personnel can get hooked, because even anesthetists can get hooked. So in terms of, numbers, there's that possibility as well, because you have access to it. So there are drugs that absolutely, if you don't want to take them long term, otherwise you will get hooked.
Thank you for that, Dr. Amanda. There's a comment here that I think is worth sharing. Jessica says that I was diagnosed with fibromyalgia a year after having my daughter. I was having problems during my pregnancy, but when I informed my doctor, I was told the pains I'm having is due to pregnancy. I had difficulty walking, sleeping, pain all over my body. I had to have a walking stick. It's been 7 years going through it, but thanks be to God, I'm now able to not walk with a walking stick. I still have residual symptoms, but the pain is subsiding. Thank you for sharing your experience, Jessica. Saying that she felt lost and unable to work. I think it's worth emphasizing that fibromyalgia is a definitive entity. Yes. And it's something that really, really can be debilitating. It can affect your physical health. It can affect your mental health. So please, if you go to one place and, you're not being listened to, like Dr. Amanda has said, try and get a second opinion and see how you can get some help. This leads very nicely to just a few final questions before we round off. The psychological aspects of pain relief. This is an aspect where obviously I have special interest in mental health, being a GP. How effective or how important is the psychological aspects of pain relief with regards to dealing with pain? How important are that? Because we know about giving tablets, we know about surgery, because you mentioned that PTSD, and I didn't realize this, but PTSD, anxiety, all those people can experience heightened sensations of pain. So how important is the psychological treatment or intervention with regards to pain management?
Well, I think it's also a known fact. This is both in religious and non-religious circles, that the state of your mind and your heart can have effect on the state of your body. There's a verse that just explains that a joyful heart is good medicine. Now that's quoted from scripture. But the interesting thing is, this is corroborated, has been corroborated over time, where people talk about even people who've been given some really bad diagnosis, those who have a more hopeful outlook, I'd say, who are more positive, and this is not 100%, this is not a medicine prescription, it's just to say that sometimes they are more likely to come out of it. So that's just one way of explaining this. So let's go back to the actual question. The thing is that when psychotherapy deals with many things, okay, usually they go into many things. First, try and process why, what, for instance, let's take PTSD, process why you've had it. The truth of the matter is, whether you're having physical pain or not, you should have healing from PTSD. You should be offered it, and if possible, psychotherapy should help you unpack all the problems that you've had, why you had it, what happened, and gradually, it's gradual. Some people, it takes years before they can, get that psychological baggage off them, whatever it is that has caused that problem. But if you can get it, you might find out that you have a more hopeful outlook, and generally your body just kind of responds to that. There are things, so if you go for psychotherapy, we teach things like relaxing techniques, changing old beliefs about pain. For instance, if you feel that once you have pain, it means that your life is over, you can't do anything. You might be able to reorientate your mind to feel, okay, there's this pain, but how can I live my best life? And in living your best life, or in trying to gradually live your best life as best as you can under the circumstances, you might find that your focus moves away from that pain, and you might feel the pain less. These are just little points. It's not in any way to take away from people who are actually going through terrible experiences and they've tried things. But these are things that could help when you add them together. Building new coping skills. That's another way that psychotherapy can help. Building new coping skills to address, to cope with what you're going through, to address any anxiety or depression that the person might be feeling. Somehow or the other, I think it just generally helps you to take your mind off the pain and live your best life. And I think it's really important that when we're able to function, you find that you're less focused on what is not so great. And I'll just give a quick example. And I'm sure this happens to everybody, but it does happen to me when you're feeling a bit. This is not a pain example. I'm just giving you an example. When you're feeling like a bit under the weather, and you really don't want to stand up and go to work, but then you drag yourself because you can't just call last minute and say they should cancel that theater list. You drag yourself and go, you're not ill, but you're just not at your best. By the time you get in the car and drive and get to work, you find out that you've totally forgotten that feeling of malaise that you thought you were feeling. So this is just a very simplified example to just say that if you're able to focus on other things, to build yourself up and get your life moving, you might focus less on the pain. The pain will still be there, not saying the pain wasn't there, but you might be able to function better. When you function better, you will feel better about yourself.
Thank you, Dr. Amanda. Maybe that's why watching football helps to cure a man flu. I don't know, but it's the jury is out there, and that's why men should always have the remote control. But that's a different,
that's a good prescription.
Different conversation entirely. As we begin to round up now, there's a question here about skin. I don't think this is Amanda's department, but it says, I have a very bad skin discoloration due to eczema. Can you recommend a good cosmetic treatment? It's difficult to answer that question without further information. So if you contact the CAN counseling team, I help out with that team from time to time. So if you've got issues relating to health, you need to speak to someone. I have done it in the past, and I'm happy to chat to you. If you contact the team, they will contact me and we can book you a free consultation. With issues regards to skin, we need to see it. We need to do a video call before we can give you further advice. This is one of the things that myself and many other colleagues do to assist the community. So, but please go through the support team that you have. The information will be in the chat group, and that will help with that. There's a question here that I really want us to take before we round up. I think I found this conversation really, really interesting. It says here, do you think doctors are quick to prescribe medication? What are doctors doing about researching about the illness rather than defaulting to medication? That's a very interesting question. I'll leave it with you, Amanda, to start with. Do you think we are quick in your opinion, do you think we are? In 30 seconds.
It's like a trick question to me, because I think that if a doctor decides to take more time to investigate, the patient is likely to feel that the doctor is not really regarding their complaint. A lot of people tend to push.
You're damned if you do, you're damned if you don't.
Exactly. A lot of people tend to push for these things. And even when you're trying to say, you know what, let's check it out, it usually doesn't, it's something to think about, I'd say. But the truth of the matter is, we've said that my specialty, we don't play with pain at all. If you say you're feeling pain, we also add a little intelligence to assess, and make sure that you're not just malingering or just trying to get strong medication to, drugs of abuse or whatever it is. But yes, we will treat pain, unless the person is lying about it. And if they are, well, you might be able to assess it. There's something I didn't write. There are other ways to assess pain, especially more severe pain. Even physiological parameters. You check the heart rate, you check the blood pressure. There are things you can
Yeah.
see that tie, everything together, and you're able to now prescribe.
Thank you. We've kind of run out of time here, and I just want to lend voice to the fact that this question is rather incomplete. When you say researching about the illness, doctors already are knowledgeable about most illnesses. So in terms of researching about the illness, unless it's a rare genetic disorder, I don't think any kind of research is required to do that. But once again, Dr. Amanda, thank you so much for taking the time to come and speak to us today. You've spoken very extensively, and we appreciate you coming. And we hope that we can call on you again next time. And I hope everyone's benefited from this. Please share this with your friends. There will be some people who will need to have heard this presentation, and this may just be what they need. So I'm going to hand over to Steve, who is going to round up the conversation. Thank you.
Thank you, Dr. Joe, and for hosting us again. And thank you, Dr. Amanda, for a very interesting session on pain management. Just before we draw the curtain for today, our next Creative Health Hour will be next week. Do well to tune in to benefit from our expertise of Black doctors. And the topic would be, let's talk about sexual transmitted infection. It's on the 3rd of February 2024 from 11 to 12:15 to register.
You're not sharing screen?
Uh,
Thank you.
so just 1 minute. Right there. So can you register at info@can.org.uk or portals.can.org.uk/HR. So give me a minute. Taking care of your health starts with your diet and physical activities. So do well to join our next Healthy Heart session. It's on Tuesday, 30th January 2024 from 6:30 p.m. to 8 p.m. And the topic is on healthy nutrition for late shift workers. Why are Black women 4 times more likely to die during pregnancy? And how can we bring this issue to the forefront of the UK public health priorities? Join us, the Black Women, Perinatal and Infant Mental Health webinar on the 9th of February 2024. To register, visit portals.can.org.uk/PIMHA event. Or you can just scan the QR code. Get involved with Homes for Health. Let's make private housing condition in Gorton better. Are you renting from a private landlord or agency? Are you Black? Are you a Black Caribbean African living in Gorton? Do you want to make your voice heard, or support your other tenants? The answer is yes. Then kindly scan the QR code, or you can contact on 07919095 262. Join us as we celebrate the Victims' Voice panel, Voices in Collaboration and Love. It's on the 14th of February 2024 at 4 p.m. We'll have keynote speaker Kate Green, who's the Deputy Mayor of Greater Manchester. There will be discussion engagements, service updates, quiz session, and a period of network opportunity. And that happens to be a Valentine's Day, so it's a double package for all. To register, just visit advocacy@can.org.uk or you can scan portal.can.org.uk/health. Black Health Inequalities Summit, and the theme is from recognition to action, community and system collaboration approach to improving the health of Black Londoners. Is on the 24th of March 2024 in London. And you can see the link on the screen to register, or you can scan the QR code. And thank you for joining us into this health hour, and see you next week.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CARN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.